bug has really bugged us for last so many years, and though now they are getting smarter and smarter, and most of the ICUs now are facing the problem of managing MDR organism. Gram negative and gram positive, both are troubling. Among the gram negative, Enterobacteriaceae, ESBLs, E. coli, Klebsiella, and among the non-Enterobacteriaceae, Acinetobacter, Pseudomonas are really great problematic organism to be managed. And among the positive, of course, MRSA is the most common organism. So we are going to discuss today about the management of MDR organisms in the ICU. So we have Dr. Prakash Shastri, who is the Vice Chairman, Department of Critical Care, Sir Ganga Ram Hospital, New Delhi. So Dr. Shastri, I'm going to ask you, why do we see so much of ESBL nowadays?
ESBL in India has been a long-standing problem. I believe from the 90s itself, ESBLs made their appearance in India. And personally, if you ask me this question, I would say that the incidence of ESBL has gone up so much because of over-prescription of antibiotics across the spectrum of doctors, across the spectrum of specialities, and perhaps because of less regulation in the Indian market, where cephalosporins and fluoroquinolones are available across the counter. So more often than not, even for trivial ailments, patients tend to take these cephalosporins across the counter and start it, and by the time they come to us, they're already harboring ESBL organisms.
So basically it is the overuse and misuse of antibiotics, in addition to all the other risk factors for ESBL, the elderly people, the stay in the hospital, and all other factors. Now once you have ESBL, of course the carbapenem is considered the best drug for the ESBLs. So what do you think is the role of BL-BLI combination in managing these patients?
BL-BLI are not my drug of first choice when I am suspecting ESBL infections in my patients. Having said that, and you also mentioned that meropenem is the drug of choice, but there are occasions where we could possibly use BL-BLI combination. Number one is the availability of MIC values. If my microbiology lab is good enough to send me the MIC values and the culture is positive, maybe, and if the MIC values are less than 4, probably I wouldn't mind using BL-BLI combinations. Having said that, even if I do decide to give BL-BLI combinations, because they are time-dependent antibiotics, I'll probably give them at more frequent intervals, and probably I'll give them at a higher dose. And because definitely there is an inoculum effect which tends to affect the performance of BL-BLI combination. And in clinical practice, when it comes to clinical cure, BL-BLIs have been found wanting. So I won't recommend BL-BLI as the drug of first choice. Yes, later on when the cultures are positive, your MIC values are known, they are low enough, then possibly you can use them safely. But at the outset, at the beginning, when the culture reports are not known, you are treating the patient empirically, perhaps BL-BLI combinations would not be my drug of choice.
Yeah, I think, many of these patients who come from outside and they're carrying ESBLs, so you really don't know whether they are carrying the sensitive organisms or not. And as you said, that if you have to manage these patients, then you must ask for MIC value from your lab. And you start with carbapenem because you don't want to miss the organism. So you start with carbapenem, and when you get the report which is growing some bacteria, and if the MIC value is less than 4 for that organism, then probably you can de-escalate to BL-BLI combination. But otherwise carbapenem will remain as a first drug of choice. Then the other organism which I think we see very often, the non-fermenters, Acinetobacter and Pseudomonas. I think when you get a report of Acinetobacter, it increases your heartbeat in the ICU, isn't it? So, so Dr. Shastri, a lot of new drugs, rather I would say the old drugs are coming back as new drugs, and the example is of course the polymyxins, they have been there since 1950 and they have come back. So I'll ask you, what are the drugs which have been rediscovered in the management of these non-fermenters, particularly Acinetobacter?
To answer your questions, I'll come back to your statement that Acinetobacter tends to increase your heartbeat in the ICU. Now that we have been living with Acinetobacter for a good 10 years, now that statement doesn't hold true, because there are so many occasions. Acinetobacter is an environmental pathogen, and since it's an environmental pathogen, it is very likely that you might get Acinetobacter as a contaminant when the sample collection from the nurse has not been proper. So my response to an Acinetobacter culture report in my ICU is to look at the clinical condition of the patient. There are occasions in which my patient is tracheostomized, sitting there in the ICU. Some other physician comes in and says that we want to have a culture report of this patient, and everything comes back as negative except that there is a coronary count of 80,000 from the sputum of a patient with Acinetobacter. These are the circumstances when my heartbeat doesn't go up. I just say that, okay, fine, it is there, we are going to observe the patient, we are not going to do anything. Having said that, colistin, I will say that we have had the dubious distinction of having used colistin the maximum in my hospital. We have been using colistin from 2006, even when it was not available in the Indian market. So Acinetobacter colistin was the first drug that we used, and then subsequent to that we have been using polymyxin B. There were few stray reports that chloramphenicol was effective, so that's why we have tried empirically chloramphenicol, but then we got a chloramphenicol congener in the form of tigecycline, which has been used. When tigecycline was introduced in the market, it raised a lot of hope amongst us that maybe this combination of drugs would be useful in curtailing the menace of Acinetobacter. But tigecycline unfortunately has not lived up to that expectations, and nowadays, recently in the last 6 months or so, minocycline has been reintroduced in the market. Initial reports, when it not exactly with Acinetobacter but carbapenem super infections in the form of Stenotrophomonas multifolia, Burkholderia cepacia. In these situations, we have found that minocycline tends to do a job, at least not alone, but in combination with other beta-lactam antibiotics. So these are the new drugs which have been rediscovered in the last 10 years in the our fight against Acinetobacter. Pseudomonas still remains a problem bug, but Acinetobacter we have been able to get some control over it. Yes, we have used sulbactam along with all the other drugs, but a combination therapy is one. I'm not a votary for combination therapy, but still Acinetobacter, Pseudomonas are a group of organisms where I would probably treat the patients with a combination therapy rather than a monotherapy.
So what are the advantages of combination therapy?
Acinetobacter and Pseudomonas, they are very notorious bugs in the sense that they don't have just one but several mechanisms of resistance, and that is why it is useful to have drugs with multiple mechanisms of action to counterbalance this multiple mechanism of resistance in Pseudomonas and Acinetobacter. That's why I favor combination therapy rather than a monotherapy.
Yeah, of course, the Acinetobacter has multiple MC, metallo-beta-lactamases, and by mutation also, efflux. Yeah. So all this, there is another drug which is now again introduced into the market in addition to what you named, the drugs like colistin, which is a polymyxin E, polymyxin B, then the tigecycline, minocycline. These are the drugs which are available as important drugs in managing these patients. There's another drug which has come into the market, and there are few papers about fosfomycin, and which is a drug which is effective against Acinetobacter, not against Pseudomonas that much. So what do you have to say about fosfomycin?
Fosfomycin holds a lot of promise, but having said that, my experience with fosfomycin is quite limited. What all I know about fosfomycin is that it is a drug of choice in complicated urinary tract infections. So my inclination, at least in the first few months of introduction of fosfomycin, has been to use where I am suspecting urosepsis as the reason why my patient has deteriorated. Now again, for urosepsis, urosepsis is not something that we are really perturbed about in the ICU. Urosepsis generally responds to the usual drugs that we give, but there are conditions when the patient comes out of the first bout of sepsis and goes back into sepsis again the second time around, and that is the time that we are really scratching our head as to why this thing has happened. At that time we don't have culture reports to go by, we are again back to our empirical method of treatment, and in those situations we have already exhausted the colistin in our arbometrium. These are certain areas, and especially when I am thinking that Enterobacteriaceae are the offending organisms. Now here Acinetobacter can be included in it, Pseudomonas probably can be included in it, but Pseudomonas tends to be more resistant to the action of fosfomycin. And yes, if I suspect that the brain is the source of infection, then I know the fosfomycin concentration in the CSF is very low, so I would probably not use fosfomycin there. So fosfomycin is not my drug of first choice, but my drug of last resort, I would say, that when situations are such that I am suspecting Enterobacteriaceae and Klebsiella has become a big problem in my ICU. These are the situations where I would probably use it when my first line of drugs have failed and I am left with not much choice as to what drugs I use. Again, fosfomycin I am not going to use alone. I am going to use a very high dose, and I am going to give it at least 6 hourly in my patients, because it is acting as a rescue therapy in my patients.
You know, Dr. Shastri, the TG cycline, of course we know that TG cycline doesn't stay in the blood, it quickly goes into the tissues. And the study which had looked at the management of ventilator associated pneumonia with TG cycline was a negative study. But recently there are reports that if you use TG cycline in a high dose, they have been able to show a cure in the patients of ventilator associated pneumonia. What do you have to say? This was an Italian study published sometime.
I'm aware of that study. See, my personal opinion is that I really don't care much that the tigecycline levels in the plasma are low. Okay, I can't use tigecycline in bloodstream infection, catheter related bloodstream infection. Those are secondary sepsis patients. I'm not bothered. When my patients come to me, they have deep-seated infection, they have pneumonia, they have meningitis, they have intra-abdominal infections. So if my drug is able to penetrate those areas, even if the plasma level of tigecycline would be low, as long as I'm confident that it has reached the tissue which is the offending tissue where the infection lies, and I am certain that tigecycline is reaching the tissue because it's a huge volume of distribution, its penetration into the tissues is very good. So there I don't mind tigecycline being used, and that is why again in pneumonia, for example, I am quite sure that the penetration of tigecycline into the lungs is not too bad. Its concentration in the blood would be low, but again into the lungs.
But then I think one can use with this study in mind high dose to manage the infection.
I agree that the penetration into the tissue is very good, but the trouble that I have faced in clinical practice is that after the first 2-3 days, while the patient is on tigecycline, the bug which is supposed to be sensitive to tigecycline becomes rapidly resistant to it. And that is where, even if I have to give tigecycline in my patients, I don't tend to give tigecycline for more than 5 days in my patient, because I know after 5 days my bacteria is going to develop resistance while on tigecycline.
Okay. So, Dr. Shastri, we have very limited drugs and we have an MDR organism. Suppose we have the cornerstone drug in the form of colistin or polymyxin B. Suppose you get a report tomorrow in your ICU that your Acinetobacter is resistant to colistin. Then what are you going to do? What are the other choices you have in that kind of a patient?
By reports in my ICU, Acinetobacter still continues to be sensitive to colistin, but the resistance to colistin in Klebsiella pneumoniae is touching 15%. So they are more common to have.
So your Klebsiella is resistant to colistin?
Extremely drug resistant. I have a patient right now in my ICU who is resistant to all drugs. It's extremely XDR Klebsiella. Now I will tell you what, I may not agree with that approach, but I'm telling you what approach we have adopted in that patient. We have seen that the patient is having in vitro resistance to Klebsiella, fine. But what we are doing is we are hitting this patient with a beta-lactam antibiotic, with minocycline, and we are still persisting with colistin because we have got high confidence in colistin being effective. So what we have done is that we have used colistin as a 9 million unit dose as a continuous infusion over 24 hours, hoping and praying that this is going to work. Having said that, I mean, its clinical cure definitely has been there. The patient has been weaned off from the ventilator, he is on TPs, but his pneumonia is still standing there. he's got a big consolidation there. So in this situation, I really can't make too many recommendations, except that there are occasions where the in vitro susceptibility may not be there, and if you adopt novel means of drug delivery in the form of continuous infusion, possibly you might still get clinical cure in these patients.
Okay. So the other thing is, in management of MDR organisms, particularly in the lung and the CSF or the meningitis, what is the role of local instillation or inhalation of colistin? Do you use it?
I don't use inhalational colistin because I don't think that the inhalational colistin actually reaches the terminal airways where it has to be present to be effective. So I am wasting the drug in the upper airway. That is why in general I believe that if the patient is improving on colistin, it is because of the systemic therapy rather than the local therapy.
But recommendations are, there are papers that you can use
Recommendations
inhalation.
are there, but I'm yet to be confident enough to, these recommendations or whatever studies have come out, I don't think the threshold limit has crossed in which that will give me the confidence that inhalational colistin does work. But that doesn't go for intrathecal colistin. We have got.
So what is the role of intrathecal colistin or the local installation of
intrathecal colistin? We have got very good experience, and we have been using intrathecal colistin for the last 10 years almost, and we have received wonderful response in intrathecal colistin, because we know colistin, if it has to be used, systemic colistin in meningeal or meningitis or CNS infections is not effective. So we have given intrathecal colistin and we have obtained good results in our patients. The only thing is that we were very careful. We have even used 1 million of colistin intrathecally almost 3 times a day in ventriculitis due to EVD drains, for example. So these are the situations where my response is that colistin is an effective drug when it is used intrathecally. My experience says that maybe colistin is not an effective drug when used inhalationally. Yes, there are recommendations to the tune that inhalation colistin can be supplemented to IV colistin. I agree, there are papers, but the papers that I have read do not cross the threshold of confidence that will allow me to believe that, because yes, we have clinical experience also to go by, and clinical experience is nothing much to go, but intrathecal colistin, definitely we have seen clinical cures by intrathecal colistin.
Okay, so MDR organisms definitely are here to stay, and we are responsible for creating them by overusing, misusing antibiotics for many years and not following the infection control practices. We missed the bus which was there 20 years ago, and if we don't take the action today, then we will be standing here where we are and we'll have no drugs to treat our patients. So when you are managing MDR organism, please think, does your patient really require antibiotics? Does he require this antibiotic which you are thinking? And give them in appropriate dose to have a maximum effect in your patient. As far as the MDR, ESBLs and the non-fermenters, Acinetobacter and Pseudomonas, they are the problematic bacteria in most of the ICUs. Carbapenem remains the drug of choice for ESBLs, but if the MIC subsequently you find less than 4, you could consider using BL-BLI combination. For Acinetobacter, colistin or polymyxin B remains the cornerstone drug. It has to be supplemented with another drug which could be a TG cycline, minocycline, or depending on the sensitivity pattern in your ICU. The role of local therapy, inhalation, there is still controversial, but there are studies which have shown that it is an efficacious therapy in addition to the systemic, particularly when you instill intrathecally or intraventricularly. But if you want to give these drugs properly, give them in a proper dose to have a maximal effect of these drugs. So once again I say, choose the antibiotic judiciously to prevent the further rise in the occurrence of MDR organism. Thank you. Thank you.